Good. Good morning, everyone. This is the second meeting of the Palliative Care Services Work Group. My name is Ben Steffen, and we're broadcasting from the world headquarters of the Maryland Healthcare Commission, or otherwise known as our offices here in West Baltimore. We'll begin by just going to ask Linda to read who's on the line, and then we'll or Tracy, one of you, so we can move quickly through our kickoff. Tracy, can you do that?
Yes, you want me to do that? Okay, so on the line we have Ted Meyerson, Allison Zabrowski, Amanda DeStefano, Cindy Carter, Dr. Deneen Boland, Donald DeQuella. I apologize if I am butchering names. Joanna Ruth, Kelly Bontran, Marion Grant, Dr. Grant, Matthew Celentano, Scott Brown, Zoram, who's actually from MHCC, Aaron Davis. Those are the ones that we have so far.
Thank you.
16 participants.
And here in the room, we can actually, since I can see you, and if you're not responding, I can nudge you, but let's go into who else is in the room with us. We'll starting with our guest.
Good morning, Dr. Chris Kearney. I'm a palliative care physician. I'm the former director of palliative care at MedStar. I'm now representing the advisory council for quality of care at end of life on this work group. I'm now, Larry Hogan just appointed me the chair of that committee, so I figured I might as well come in person and introduce myself.
Congratulations.
Congratulations.
Or, yeah, I sentenced me, I think, get pardoned, sometimes get sentenced.
Parting gift.
Right.
I'm Kathy Howell, the president of Gilchrist.
Welcome, Kathy, as well. And
You wanna go-
staff on the line, we'll start from the right, my right.
Good morning, Kathy Weiss, work with the team with Linda Cole, Maryland Healthcare Commission.
I'm Stacy Howes. I'm the long-term care quality initiatives chief for the Center for Quality Measurement and Reporting here at MHCC.
Hi, I'm Tracy DeShields. I'm the Director of Policy Development and External Affairs for MHCC.
Linda Cole, Chief Long-Term Care, MHCC.
Okay, so we want to move into the agenda items. And first off, we did circulate a summary of the first meeting. We don't formally vote on the meeting summaries, but if anyone had any comments on what was in the summary that they think is incorrect or needs to be added to, we'll consider that at the moment. Everyone's fine with that? On the line? Okay.
And is there anyone we missed in terms of attendance?
We can continue. We'll know who comes into the room.
Okay.
I'll bet you. And for those on the line, if we can kind of monitor that. And if you were not here at the beginning of the meeting, which you were not here, you wouldn't know this, but we did en masse introduce everyone. And before you speak for the first time, if you weren't here, introduce yourself. Why don't we do it that way? Last meeting, we did ask the payers for some comments on their reimbursement policy. We did get communication from Care First. That's the only one. Linda, did we want to talk about that?
Well, what I was going to do is go through the payers and call on them to respond. So starting with Medicare, we have Cindy Masuda and Kelly Bontran. So asking for your comments in terms of what the current status is for financing for palliative care.
Hi, I'm Kelly Von Tran. I am the Deputy Director of the Division of Home Health and Hospice here at Medicare. Right now, payment for palliative care primarily is found under the Medicare hospice benefit, which, as many of you probably know, is a per diem payment for each day a beneficiary is under a hospice election. Currently, there is no separate palliative care benefit in which there's a separate payment for those types of services, though we hear often that these services are provided in different settings and are usually covered under those respective payment systems.
So basically, there is hospice, but there's no separate palliative care payment at the moment.
That is correct.
Thank you for that. One of the challenges with the Medicare hospice benefit is the foregoing curative care with the palliative care patient. That determination might not be a choice that a patient wants to make. How does that work when a patient is exercising the hospice benefit but is truly using it as a feature of palliative care? Kind of informal.
All right, so you're basically you're saying a patient who's under hospice or a patient who's not under hospice?
A patient who's under receiving the hospice benefit.
Okay, well, so, go ahead. I'm sorry.
But Kathy,
Yeah, in our program, there are certain that are inexpensive enough that we cover it under the hospice per diem. And then we also bill Part B for palliative care consults. Our providers bill Part B. Go pay for it, but we do get that additional compensation.
But other team members would not be reimbursed in any way. Your social worker, no one who cannot do professional billing.
so
You just follow the cost.
Physician.
Physician or nurse practitioner.
Do you want to move on to?
Other questions on the Medicare benefit from anyone?
And, the CMS did have the CMMI demonstration project for concurrent care, which ran for 5 years. And our understanding is we were one of the participants that it was demonstrated significant savings. But we have not seen that expansion to the benefit. Kelly, I don't know if that's something you can comment on, maybe not, but.
That actually was in our Center for Medicare and Medicaid Innovation. I don't think we have anybody here on the line that could speak on it. I know Cindy was involved early on.
I can.
Okay.
Marion wanted to comment.
So the Medicare Care Choices model was expanded by a year, was financially successful. Because the enrollment criteria were so stringent, they were not able to enroll enough patients. So even though they showed a financial benefit, they didn't have a large enough sample to change the entire Medicare program. So that was a test that ended well, but was not expandable.
Thank you. Any other comments on the Medicare benefit?
Yeah, real quick, I just want to clarify something. So currently, the palliative care payment is built into the hospice benefit. So essentially, for patients who are not on hospice, the only payment model is a fee for service for either a physician or advanced practice provider. Is that correct? Am I hearing this correctly?
That's correct.
Thank you.
Our knowledge.
And who asked that question?
Donna Quill.
Don D'Aquila.
Very good.
Okay,
Go ahead, Linda.
yes. Okay, For Medicaid, Joanna Ruth.
Meeting is being recorded. Sorry.
Hi, how are you? Sorry about that. So Linda, I actually emailed you about a minute before this meeting started, so that's my fault. I apologize about this. So the MCOs pay for hospice through the capitated payment that we pay them, and then we do have a fee for service. Again, similar to what was stated by Medicare, we don't specifically cover palliative care. We cover something through hospice. And then there are potentially services that would be considered palliative care services that we pay for, but not specifically as palliative care. So someone might bill for something and be considering that within their own practice as palliative care, but it doesn't necessarily mean that that's how it's treated and financed by Medicaid. I don't know if that makes sense. And then as a follow-up, to the question about what happens if someone needs, for instance, let's say someone has elected hospice care and then therefore can't have curative care, they might get, like if they break their leg, hypothetically, they might get disenrolled briefly from hospice to go into the hospital to have that fixed and then get re-enrolled in hospice. That's my understanding from folks on our team.
Okay, but that sounds like it's an acute episode that's temporary, but it's not, then you can have palliative care. It's just dealing with the broken leg. I
That's right.
understand.
So again, in practice, it's a provider-only compensated service.
Right.
So there's no social work. And I don't know where we're putting advanced care planning, whether you're considering the palliative.
Well, when we get to the survey questions, so get into that too.
The advanced care planning for Medicare is compensated. For providers.
And that's your example of the people in their office doing this. They would be billing for advanced care planning typically reimbursed. I wonder if medical assistance has any plans or had any plans in the past or in the future to cover palliative care for their MCO patients.
Joanna, I don't know if you heard the question.
I heard the question. I would have to take back about in terms of what future planning looks like. And I can give that answer via email before our next meeting.
And there is concurrent care under Medicaid for kids. For children who are
Okay.
receiving hospice services, so. That is something that we've addressed.
Yeah,
at the state level.
and the advanced care planning feature, just for the record, is noted that the care population that's not heavily used, based on our data. Looking at the Medicare Part B files and those codes, it may occur, but it's not billed commonly. And one of our initiatives from other programs that we're engaged with, the Maryland Primary Care Program, for example, we are trying to work with primary care providers in particular, and that's of course non-institutional patients largely, to advance the idea of doing some ACP activities, a little bit outside the realm of what we're doing here, but definitely related. And certainly some of the ACOs, particular Allidaid, have purchased a advanced care planning entity, Iris Health, that basically recognizes that maybe a step further along on the continuum, that maybe the idea that primary care physicians are good at this is not so true, and that having professionals is mostly physicians and other non-physician professionals really take on this role is a way to elevate use of ACP. But I think we'll talk more about that as we move on, but since it came up, the idea But once you get outside of your sort of the hospice environment, been a tough road to advance in our experience.
On to Care First, Dr. Deneen Boland. I know that you did send a statement. It sounded like the statement encompassed both hospice and palliative care, didn't really differentiate, so whatever comments you have.
Yes, right now, it's actually probably similar to what everybody said. We don't have a separate palliative finance. And also, our hospice and our palliative service are by the policies are really based a lot on members' contracts as well. So depending on what the employer groups may or may not decide, upon. So we don't have a separate palliative, I guess, kind of payment process as well. And that's for our commercial plan. We, as you know, we have a Medicare Advantage program as well with Care First, and they do have a palliative service that we were just recently working with, Aspire. So they have a set program with that. So.
And what does that include?
And that I am not on that as much. So that, as far as I know, is just palliative services. It's a set price with the vendor that they coordinate. I can certainly get more information going forward, but I don't have a lot of details. I think it's a relatively new program that we're utilizing with them.
And what is the name of the subcontractor you use? I didn't get it.
Aspire,
for
profit.
Dr. Grant, did you have a question?
Yeah, I just had some contributions to this discussion. So I think the easiest way to think about it is that hospice is palliative care provided to people at the very end of life. It is an approach, palliative. Do not confuse palliative care earlier with hospice. There is a Medicare benefit for people in hospice, but there is not any kind of formal benefit for people for palliative care pre-hospice. There are creative solutions to that. People bill fee for service, people bill value-based. There are groups like Aspire, which contract to see patients with serious illness and provide symptom management mostly. It's not the kind of holistic care because at the moment, no funding can pay for the kind of holistic palliative care that we're talking about. But we're going to find out with the survey, how many people, despite that, are doing bits and pieces of palliative care in the state. But I think we have to, that was my comment on the survey. We have to separate palliative care from hospice. They are the similar approach, but the palliative care we're talking about is for anyone with serious illness at any point in a serious illness, not somebody enrolled in hospice in the last days or weeks of life.
Okay, thank you. And yeah, I think that distinction is important. And when we get to the survey, we will have the definition up front. So when we survey programs, it will be clear what we're looking for in palliative care.
Just a follow-up question for Care First. I remember that in times past, actually Care First was developing or did have a benefit for palliative care that was similar to their Medicare benefit in the commercial range. Did that go away or what happened to that? Or do you know?
I actually don't know. I mean, there is the benefit, but I don't think it's quite separated out based on we have a policy that we have for hospice, but a lot of it is a benefit driven. So I can find out more about that. So you were saying that Care First in the past had a separate palliative for the Medicare supplement?
I'm not sure, no. It was in the commercial. I'm quite certain of that. We met as MedStar, we met with Care First when we became aware of that palliative care benefit. It was unique, we thought. But now I'm not hearing that you're saying they're still carrying that or having that.
So you're saying it was
Also covers a fair amount of concurrent care, Ben, to your point. You can have, especially for the younger commercial population, you can have curative treatment alongside your hospice benefit. under many circumstances for the commercial.
Right, I mean, in the policy that we have, like, it comes under that hospice, but it doesn't really well define it, I feel, how, looking at the definitions and so forth, but there is, under that palliative, and it's not well written out or very detailed, but it's still allowed for, treatments such as therapy, chemo, and so forth. That's still there under that palliative part, if that's what you're asking.
Yeah, it had a name. Do you remember the name?
Do not.
So Dr. Kearney, just to clarify, you said it's the commercial plan, but it follows the Medicare model.
Essentially, but it made people eligible for palliative care without becoming outside of hospice, without being within 6 months of end of life or giving up on continued, interventional care.
Okay. Do you remember when that was?
Oh, in 17, 18, somewhere in there. Tim, who's your predecessor?
I'm gonna get you the name. I'm texting somebody. They don't.
Tim Cox.
Tim Cox is correct.
Yes. Okay,
That's who I would talk. That's who we did talk to.
okay.
I'm sorry, what was that?
His name's Tim Cox. He's a former. I'm not sure you would know his former role. He's not with you now, I think.
Yeah, he's not with us anymore, but I have met him. But I'll find out for sure and email back. I think it's still probably there, and I guess the information that we sent to the team today on the policy, I think it's just it may depend on the group's benefit, but there is palliative services available, but how well defined it is by that policy that we sent in may not be clear, but I'll check on that and the team that worked with Tim before.
So this has been Stefan again you mentioned that this was a contract by contract option in the commercial market. Given that it's not part of the standard offering in the commercial market, wouldn't that be pretty a fairly pricey benefit, given that people who want it would be more apt to use it? Or do you have any insights on who's picking up the benefit? I don't really know off the top of my head whether the state employee plans, which would be something that Care First, United, and Kaiser would all have to offer, includes this or not, but any insight there on the number of contracts that actually pick up the benefit?
I do not have any insight there. I can look into that too.
Thank you.
And
Sure.
thank you. We have Matt Celentano, who also has been digging for information on this.
Welcome, Matt.
Thanks, guys. I appreciate having the opportunity. So overall, I think the carriers in the league that I sent along the survey to struggled with the question of financing. Most of the questions in the survey were really directed at providers, not at payers. That being said, I'm not sure how I would answer the question of how is palliative care financed by carriers. I will say it's hard for us to quantify how it is financed outside of insurance coverage, and sort of like what Dr. Boland had mentioned, it is a contract by contract basis. But I think that overall, you could say that the 5 carriers, the commercial carriers operating in Maryland, have some sort of hospice / palliative care benefit in pretty much all the plans. They all approach it a little bit differently. I wouldn't say that it is uniform by any stretch of the imagination, but I would say that for the most part, palliative care and hospice care are sort of treated as one and the same. And I know they're very different, but a lot of the services have crossed both sort of approaches. There are some carriers that are doing some pilot type programs that are using specialty social workers to triage approved documentation, that kind of thing. But most of it is looked at as a benefit. And as long as it's medically necessary, all 5 of them in some capacity cover things from counseling to nursing care to social services to physician services, respite care, the list goes on. And they're all sort of listed a little bit differently. There's a particular Aetna CVS program called Compassionate Care Program. United has their own approach. Kaiser has a palliative care specific sort of approach on documentation. You have the Care First policy in front of you, and Cigna does something sort of the same. So the long answer to get to the short particular thing is, yes, it's covered. It just depends. What I would say is that in the future, if we want to keep going down this hole of quote unquote financing, which I had mentioned was harder for us to sort of define, if there are specific CPT codes that folks are interested in finding out, if I could get those codes, I could go do a survey of the carriers and find out a little more in depth if that's covered on a sort of policy by policy basis.
Okay, I think that's helpful, and as Dr. Grant mentioned earlier, we're trying to assess what the current situation is and then look at what we need to do to broaden financing or make changes going forward.
Yeah, I mean, I'll just follow up. I think everybody knows that it is a benefit that is a part of your policy. I will say that all the carriers acknowledge that palliative care and hospice care is different, but it sort of fits an insurance bucket in the same, if that helps.
I would, in practice, I would just share that the Aetna Compassionate Care Program is more of a concurrent care benefit, meaning that you can continue some curative treatment at the same time you're receiving hospice. We have not had any success in having what we would call outpatient palliative care services covered under that program, but much success with concurrent care. So, I still think there's a lot, to go back to Marion's earlier point, a lot of confusion. I think people think they're covering palliative care because they believe hospice is palliative care. But this other freestanding work that's being done in advance of hospice, again, our experience is largely not funded except under the professional service fees.
So when you say Aetna Compassionate Care is concurrent care, but outpatient, is that inpatient care, the concurrent?
No, it can be home-based, but if you, for example, if you want to dialysis, okay, under the Medicare benefit, that is cost prohibitive, but Aetna will pay for your dialysis at the same time that you're receiving hospice care. Because their internal studies indicate that people will move to hospice and give up that dialysis sooner when those conversations are going on concurrently.
So I just want to chime in one tiny bit here and say that a part of this discussion gets, as you guys know, very complicated, because if you are Medicare eligible, you're probably not buying a commercial plan, and the opposite as well is true. So crossing these types of sort of stakeholder or marketplaces makes this extra complicated.
Thank you.
Okay. Ben, did you have any further questions?
I did not. Other questions, first off in the room?
Dr. Grant?
Yeah,
And-
I think having known Dr. Randy Krakauer, who started the Compassionate Care Program at Aetna, I think he would describe it as a hospice program that they made available to people longer than 6 months from death and including concurrent care. That he would not describe it as a palliative care program. So again, I know there are overlaps, but that is really for people at the end of life.
Tracy, you said there was another
Just
question.
from Kelly. Her comment is that is correct. There's no separate palliative care benefit in Medicare outside of the Medicare hospice benefit.
Okay. All right.
Okay,
So there's nothing else on that. We're going to move on to
Yeah,
the
and
survey.
just, you want to try to characterize what we just heard, Linda?
Well, I think what we've heard is primarily it's very difficult to separate hospice from palliative care. A lot of the benefits in either the Medicare, Medicaid, or commercial payers is a hospice benefit. There are bits and pieces of palliative care covered. And hopefully during the survey, we can try to dig into this further. And then, as Matt had mentioned, if there are certain codes that we identify, we can see to what extent that's covered and then make
Yeah, I
recommendations.
mean, that's basically gonna pick up the professional billing. That kind of have a good idea.
Right, and then we need to see in terms of recommendations, ultimately, how we broaden finance.
All right,
Hey guys, real quick, this is Don Diaquila online here. Quick question. So in my experience, and I know we're talking about Maryland specific programs, but the VA tends to be ahead of the curve on these types of things. I know that they are very well versed in concurrent care. My question is that something we looked at? And does anybody online, maybe Chris or Miriam, have experience with what the VA does with palliative care?
we had not particularly focused on VA, but that's a good point. I don't know if we have anyone.
I think Miriam has her hand raised.
Okay,
So my understanding is that the VA has actually a very comprehensive program. They allow concurrent care in hospice in many situations. And then prior to that, they have palliative care at all of their medical systems. And they have very good referrals to palliative care. The difficulty with looking at the VA is that it is an integrated health system unlike anything else in this country. And so it is an example of what you can do when you have a fully integrated health system, but lessons learned there are usually not easily applicable to the rest of to other payers or other health systems. So we can look at it. We can certainly ask in Maryland what's happening at the VA, but it's kind of nice to know, but not really going to inform anything we can do in the commercial or in the Medicare market. I wish it were.
okay, thank you.
If I could just quickly, for the Care First, for Dr. Bolin, the program was called CPI. And
Sorry, what was it?
T is in Tom, C is in cat, C is in cat, I. And it's been discontinued.
Okay. Thank you.
Thank you. I had a little trouble getting unmuted, so thank you.
Sure.
Do you know when it was discontinued? Did you see it? I mean, I unfortunately, I've been at Care First since 2019, so I wasn't aware of the program in 2017 or 18.
I want to say in the middle of COVID, 2020.
Okay.
We still call your plan often to negotiate, additional concurrent benefits. And if it's in the person's plan, we're able to get it, but you used to have a formal program.
Okay.
To
And
move
I
those.
apologize. I'm not sure who's speaking. I imagine you're.
This is Kathy Hamill.
Kathy,
Kathy. Okay.
Thanks.
Hey guys, one more question here regarding the Medicare Advantage plans. I know utilization in Maryland's pretty low, but the HSCRC has recommended an uptick in the utilization of those resources potentially. In my understanding, some resources that come from these types of programs always aren't labeled palliative care. Sometimes they can be labeled as serious illness programs. So is that something we've looked at? Are there any serious illnesses or programs that probably pick up palliative care populations? Are there any resources or programs in that realm?
I'm not aware of any programs in the commercial market that offer that. I think that Medicaid may have, but Kathy Hamill looked like she is about ready to speak. Who is asking that question?
It's a Don Diaquila.
And just,
I think PHPP has a serious illness carve out.
and it's my understanding that the proposal that was HSCRC crafted for CMMI to allow a bigger differential for Medicare Advantage plans was denied a year or so ago. And there are some ideas on some additional state funding for Medicare Advantage plans in the short term, focusing principally on the dual population, the SNP population, and certain jurisdictions that have heavy Medicare Advantage participation. Those payments are short term. Naturally, much of the work is focusing on, handing off to the Moore administration. But I think the Hogan administration is very, very reluctant to make long-term commitments regarding these sort of state what are private sector health plans, commercial health plans serving a Medicare population. So stay tuned on that. But I think the HSCRC's stepping in to allow negotiations. That's gone.
Kathy, what is PHPP? All right, yeah, you can just send it to me at some point.
No, I think we want to move towards, if we have no other questions, we want to move to a review of the draft survey instrument.
So we did send out the survey for review prior. You've got that in your mailing. And just want to clarify, this survey is going to be, when it's implemented, will be emailed to the providers and then followed up with telephone interviews, because we realize these are not simple yes/no questions. So the interviewer will be able to probe and follow up to get hopefully detailed responses. We did receive comments from Dr. Grant, and I imagine most of you have comments, so feel free to jump in, and I will be reviewing this section by section. So this is just breaking the survey down into parts. So the first part is basically the introductory questions. And as I mentioned, we're going to be providing the definition of palliative care. We discussed this at the last meeting. It's the CAPC definition. I can show you again if that's needed, but when we do the actual survey, that will be in a box at the beginning, so it's clear what we mean. And we want to collect data on formal programs that meet the definition, not, yeah, I take care of people who are in pain, so I do palliative care, or I take care of people who are dying, so I do palliative care. So it's formal programs. We try to separate it from hospice, and also we'll get into this later. And I know I discussed this with Kathy previously, that when we looked at the CAPC data, it looked like care was provided at nursing homes. But then when I looked at who was doing it at the nursing homes, it was in fact hospices. So we'll get into that discussion with site versus provider, but you want to acknowledge that it's done at these nursing homes, but not double count providers. So anyway, we'll get into that. So just open it up to questions, comments on the introductory questions.
I think you can move ahead, Linda.
Well, I know Dr. Grant had a couple of comments.
Well, I wasn't sure what the forum was. Do I need to reiterate them?
If you made them in something you've sent in, I don't think that,
Yeah.
I don't think it's
mean,
necessary.
I just think just a couple of them. One, where we say you have a formal program separate from the Medicare hospice benefit. I think you felt that saying this confused hospice and palliative care, but what we were trying to do was the opposite, to say this is not hospice.
Yeah, so I think if you're going to survey people who are actually doing palliative care, they're going to know that. So, if you send this to even to hospices in the state and say, are you doing palliative care? They're going to understand that that's not hospice. So right. I mean, I think depending on who we send this to, that's going to be not a confusion point. I think bringing the hospice benefit would be potentially confusing, putting my palliative care hat on. I was like, why are we talking about hospice? This is palliative care.
Well, it would not just be hospices. As we've discussed, we'd be surveying
No,
home health agencies, nursing homes, hospitals, other providers.
right, and I think that, again, if we open with the right definition of palliative care, that so that it is clear it's not hospice, I don't see how they would have that confusion.
Okay. Anyone else?
But I hope that the group can come to terms with that confusion, because it's going to make our work much easier if everyone is on the same page about what it is and isn't in regard to hospice.
Well, I'll just say that ours is incorporated as part of our hospice, even though it's a separate group of NPI numbers. So I had some difficulty understanding what you were asking for here, and also where it said for hospitals only. We are the palliative care team for a number of hospitals. So we weren't sure where you wanted us to potentially.
Okay, are you on the first three questions?
Sorry, no, I'm on 5.
Okay, anyway, so I guess just the comment about if number 2, where we say separate from Medicare hospice benefit, hopefully, actually what I can do is go to the last slide. So this is the definition that we talked about, and it clarifies that it's appropriate in any age, any stage, along with curative care. So if we put this definition at the beginning of the survey, it will hopefully clarify that this is what we mean and this is not hospice.
Can I ask a question about the definition again, Chris Kearney? This definition is CAPC's. Does Maryland, in the CAPC resource toolkit, they actually cite Maryland as having their own definition of palliative care?
I'm not aware of
Who, I wondered, Marion, do you know anybody who owns a definition of a Maryland? Is it, or is it CAPC's?
I think it's probably CAPC's, and I would go with CAPC's.
Yeah, I don't.
I just thought it was interesting that CAPC cited Maryland as one of the states as an example to look at for a definition of palliative care. And I can't say I was aware of it, but so.
I don't know if
We're
it's
still
just
thinking there with CAPC.
legislation. As you know, there was the hospital palliative care study.
That's
and
right.
This one, and I don't know if they're citing the legislation as, I mean, it doesn't really define it.
Good.
All right, so I can go back. I just wanted to clarify that that's where we were in terms. Okay, so the next section is the organization of the program. So questions 4, 5, and 6. And Kathy,
You might need to speak up a little bit.
okay. Kathy, you had a comment on the hospital part.
Well, if you have contracted with a hospital to provide their palliative care, where would we put that?
So you're saying it's not the hospital having the contract with the hospice, it's the hospice having the contract. So maybe it should be for providers, what kind of relationship do you have with other types of providers?
Yeah, or where does your program provide services? And hospital would be one.
Well, I think we do ask later referrals.
So I have a simpler operational question. If we sent this to a hospital, would they bounce it back to you, or would there be personnel in the hospital that would be able to describe their program?
I think they would bounce it to us.
So with the nursing homes.
Right.
I think that, hi, this is Erin Davis with the MHA. I think that we have to be clear as to who is to answer, because hospitals do have different arrangements. You know, some they are their own employees, some they are contracted. Because otherwise, I think we may get duplication.
Yeah, I think how we administer it, I think we should, if we're going to survey hospitals, survey hospitals, and if they like to have their hospice agency fill it out, we have to have a way to distinguish that. I think it would be a mistake to send it to a hospice and say, fill this out on every place you have a contract.
Yep.
That'd probably be misleading.
Well, Erin, I would think that before we conduct the survey, we would ask MHA to identify the best person, the best contact person or department in each hospital, because it may vary.
Oh, absolutely.
We should get the survey. So,
Can I ask, this is Marion Grant. I wasn't quite sure what the purpose of this question was. I think we're trying to figure out, are you asking about hospital-based palliative care programs as opposed to community-based programs?
right.
Both.
I mean, the hospital only one
This
is
question is so hospital.
referrals.
Right,
Sorry.
so maybe the question should be for hospital programs. And then I think again, we keep bringing the hospice and end of life thing in, the relationship between your palliative care program and local hospices. Okay, so if you contract Kathy Hamill's Gilchrist group, where I'm actually working today, they're going to know to have the Gilchrist people fill that out. But if you send it to University of Maryland, where I work this Friday, and you ask about local hospices, we're going to think, do you mean referring patients to hospice? So that's why I think you're trying to figure out who is executing a palliative care program at the hospital, right?
So maybe the question is, do you have a palliative care program? Do you run it yourself? Do you contract?
Exactly,
with
or do you
someone else?
contract it out? Because if you could contract it out with a hospice, or presumably you could contract it out
Organization.
with some other community-based organization, yeah.
And then it could be organizations like Aspire or, right, so just listing.
They typically don't do hospital work, but
they
you
do
know,
not.
because this is all a very vague area, this would tell us who else are possibly doing hospital programs.
Okay, so you're saying for hospital programs, do you have palliative care program? Do you run it yourself? Do you contract out? If so, with whom?
Yeah, I think that's a lot more clear.
And then 6 is kind of the organization of the program. I know under E, Dr. Grant added, do you use telehealth? And I guess you also felt that just listing the accreditation organizations, we didn't have to specify who used what.
Yeah, if they're accredited, they know with whom they are, and if they're not, it doesn't matter.
Okay. Yeah, I mean, I think we will probably do our planning in terms of jurisdictions, not zip code level. So that's why it's listed as jurisdictions.
But I just have to say, as a clinician, I didn't know what jurisdiction meant. I thought it was a legal
It's a
thing.
county. It's a county.
Oh, well, so, but if you send it, if I get asked to fill this out for Maryland, I wouldn't know that, so.
All right, anything else on this part? Okay. The next section is patient services, basically. Question 7. Trying to see if it was. And then I know, Dr. Grant, you added, what services do you provide to family caregivers? Do you have a bereavement program? Which hopefully will not be confused with hospice. So, any comments on this section?
I wonder whether I can make a general comment about the survey writ large. I did have an opportunity to talk with some of my past partners and University of Maryland people as well. The survey is quite detailed. It's quite long. It's a little bit onerous, actually, in some people's opinions. And I think the question that kind of kept coming back to me is, what is the, again, I'm sorry to just break in like this, but what's the Healthcare Commission's responsibility back to the legislator? What we're trying to find out? There's a lot of detail here that would overwhelm anyone, including us. And how, is there any thought that this could be distilled in any way, sharpened our focus? So what is the question we're really trying to answer for the legislature to help improve palliative care in the state of Maryland? And a lot of this is interesting to me in the, in the weeds, but I wonder if all of this is going to be useful in the end of the end product of what we're going to present to the legislature. So I'm sorry to just throw that bombshell out, but I know all these questions, and they can find the answer. Someone will dig long and hard to find them. The questions I would guess is some of this is already being reported. CAPC collects a lot of data from the palliative care programs in the state. The Palliative Care Collaborative, Marion will know more than this about this as well, collects data. And my question is, for a lot of the programs, they're already giving data to somebody, and it has been collected for some period of time. So I didn't know whether helped us create the survey had also already evaluated what we already know, and are we being redundant in some ways? Is there a way that we could at least find out some of these questions that are being reported now and make this a little more bite-sized, not bite-sized, but at least something these programs can handle? So as a general comment, that was what I heard.
The legislative intent is quite broad. And in addition to financing and collaboration and public education and physician education, all of which will be separate, the main thing here is where is palliative care provided? Where is it not provided? What are the gaps in services? How do we address that? And as we've seen from our discussion of people who understand palliative care, it's complicated. It's not like saying, do you have a pediatric unit? How many beds? How many patients? Right. So even just defining it. What we did was, there was some discussion at the last meeting of CAPC, and that the data is hospital focused and not really very useful in terms of providers. Like I said, it looks like nursing homes are providing the care when in fact they're contracting. And it had some community-based providers. What we did was look at other states and what they had done in terms of surveying. This particular survey, when we based it on and did some modification, was done 3 times in Colorado and has been modified. It's been done twice in Maine. So it is based on people who've had experience trying to clean this data and use telephone surveys to really probe and get detailed responses. So hopefully if it's a discussion on the phone, it's not quite as bad as just fill this out and send it in.
Yeah.
But do you think a fill out a form option is, use your term, maybe less onerous? Is that what you're saying, or just the number of questions are not, on point?
I'm wondering if they're all on point. I mean, I think they're useful for someone to know this, for standards for palliative care in the state of Maryland. And but I'm wondering, to promote. I mean, I know we're trying to find out what the state of the state is for sure, and then how to promote it further. The palliative care programs are going to often go right to financing. The hole that we just talked about is where people are all going to be, involved in. But some of these other questions are not going to. I don't think they're going to tell you that much. That's going to. I guess that's my feeling. Maybe some of the specifics.
I think it's not only where is it provided, but the gap, really identifying the gaps in services. I just wanted to follow up with Dr. Grant, because I know at the last meeting we had talked about CAPC, and I don't know if you have any more information from Palliative Care Collaborative in terms of what data exists.
Thank you. I don't have an update other than that there there used to be 3 registries that collected palliative care program data. They have now been merged into one registry. And those reports are available, but I don't know how updated they are and how many people, frankly, at Maryland hospitals participate.
It would be interesting to know though, Marion, I think, because that is what the palliative national scene is what people are trying to do, is to consolidate
Right.
this so everybody isn't asking their own.
My
Yeah, and
understanding
I
was-
think that that's a quick check of the
Yeah.
registries. You know, I think that CAPC has a link to the registry page and you can see, but again, it's not often updated. So I think it gives you a very broad look.
And I thought it was also primarily hospital based.
Probably is.
And it is entirely hospital-based, yes.
Right,
Yeah, I
and
think
the
that's
I believe at
focus
this
here is programs and trying, part of this survey is getting to the last question, which is what other community programs are out there that we're not aware of? So if we go to the licensed providers, where else would they send us?
Under F, I might suggest that we just say, where do most of your referrals come from? That hospitals. We get a fair amount of patients calling out.
So where do your patient referrals come from, and then what were the choices?
Hospitals, physicians, patients and families, long-term care facilities, maybe an other category.
Long-term care facilities, meaning nursing homes.
Yeah, or assisted living. Or even independent living in CCRCs. Get a fair amount. Yeah. So I don't know how granular you want to get to.
Exactly. For the hospitals, for instance, oncology, intensive care, emergency room are valid. The main source for most hospitals, actually the hospitalists, the general hospitalists who are caring for patients, is where most palliative care consults come from, in my experience. But
So
We want it too granular.
yeah, right. I'm arguing about, that's my own point.
So Kathy, we suggesting that for F2, or it eliminate 1 and 2 and just for F?
I think just for F, and then put those categories, like how many do you get from the hospitals, how many do you get from long-term care, how many.
All right. So you're saying we don't need hospital departments?
No, because I think people will only answer that. I don't think that's where the majority of the, especially for the community-based work, it's not coming from hospitals.
Right, although, you know, putting my hospital hat on, and again, to Chris's point, maybe it's too much information, but if we're talking about medical training and you find out that within the hospital, you know, palliative care programs that respond, that most of the referrals are coming from emergency department or hospitalists and very little from oncology, I don't think that's going to be true. Would you then target oncologists with training? So I think I hear what you're saying, Kathy. I think for community-based programs, it can come from a wide range of things. If we're interested in where it comes from within the hospital, then I think knowing which services refer could be helpful, but maybe it's too much information.
Yeah,
Well,
Mary,
then-
I agree with that. If you're interested in identifying where the gaps in the inpatient, you know, where there are opportunities to increase appropriate referrals, the service line data is probably valid.
Right, so we could modify F2 then and keep F1. That probably would be best.
An additional question that might go into the hospital side is, do you screen for palliative care needs for admitted patients in the hospital? That's where a lot of programs actually do wind up at least investigating whether there's palliative care need. And a lot of hospitals do have a screening tool.
I think you asked that somewhere.
Somewhere, I can't remember. Maybe further down at the.
What metric? I don't see that. Where do you
I'm
think?
I'm
that
trying to
would fit?
remember in question 8 or further down, I'm hard to jump pages.
Yeah.
You may have included, I can't remember.
Well,
We'll come to it.
we'll look as we go through it.
There's a question, Chris, in question 5, what kind of situations trigger a palliative care consult?
Yeah,
And that
yeah, there you go.
begs the question for me of, are we talking about people who do use screening tools or triggers?
Yeah. And trigger is not actually a very good term. Most people stay away from it because it means you're somehow automatically expecting a palliative care consultation. Doesn't work well in the hospital setting.
Okay.
Most physicians don't like.
They don't like triggers.
All right, now we're at our favorite section, financing section. And we didn't already beat this to death earlier, we can do it now. So,
And I kind of want to be, I think, I want to Chris's point, the legislation was a provider-based piece of legislation that the commission agreed to take on, but I've seen the financing is kind of the core reason that the providers went to the legislature to begin with, because it's, as we've heard, it's kind of catch as, works here, fits in there, but there's not a defined palliative care benefit in, as far as I can determine, in commercial or the public payers, and people have pieced it together. And obviously the legislature can't dictate what Medicare can do. It kind of sort of can with Medicaid,
Right.
Certainly for commercial products sold under the MIA, under Maryland insurance law, they could. And I don't think that the legislature is at this point, but I think they're very curious as to, and agreed with the industry that more clarity on reimbursement is needed.
right, and I think at the next meeting, we're also going to talk about financing in general and where to go, but as we discussed, this is trying to collect what exists now.
Yes.
To find out where the gaps are. So it talks about the payers. We try to differentiate the payers from by what mechanism. Providers includes codes. So just any comments, like Dr. Grant has comments.
Yes, thank you. I actually didn't have a lot to comment on in this section. I just think that it reflects a bias towards only fee-for-service payer arrangements. And I think there needs to be somewhere a question about value-based contracting,
Right.
because that is actually the way that the Aspires and some of the people who are even doing it in the community. I don't know, Kathy, you and Gilchrist are probably doing value-based arrangements as well. So, I mean, I think that we should be asking about that and not so much about codes and fee-for-service, because we know fee-for-service is limited.
So we do have a question in 8. Are any of your services covered under value-based contract?
That's Dr. Grant's edits. She added.
Okay, okay.
8C.
Yes.
I think it still might be useful to have the codes, because as Matt mentioned earlier, if we can identify that, then we may be able to follow up to see under payers what's currently being provided. So hopefully we can include both.
Do we have any interest in collecting with some kind of a range, the annual losses that are being covered?
I guess this be for hospitals, for community
For any
providers.
program that's responding?
Okay, so we have cost savings. You'd add losses.
Yeah, I just wondered if like less than 100, less than 250, less than 500, and then less than 1 million or greater than 1 million, just to give us a sense of
Who's subsidized?
Maybe an open-ended question on,
how much,
on-
you know,
on the
each
service.
program wants to
Yeah.
say, I'm losing,
Are these,
but getting a sense of gravity for
Yeah, I
how
don't know
much.
that we.
I would be hesitant to put a question in losses only, because because there may be some that have figured
Well,
out.
or maybe it's zero.
Well, it may be a general, if you're having savings, you could also, or losses.
Yeah.
And not
I think
get
we
it
could have a
quantified.
positive to negative range.
Good point.
Can I have a point of just clarification? The HSCRC it has not been mentioned much in this discussion, but is that the same as value-based? Is that the same? Are these terms equivalent, or they are deciding things about how people are being reimbursed?
But I think with the total cost of care model, and I don't want to speak for HSCRC, that the scope of what the state is accountable for, extends beyond the hospital realm. The question is, given the authority, how does the state with only carrots, and in the case of the hospital system, there are both carrots and sticks, but elsewhere it's only carrots or implied sticks. How do you put all that together? There's about a half dozen work groups that are focusing on engaging non-hospital providers and, as importantly, consumers, in the model that's, getting underway. And MHCC is working on the one on post-acute care, which, at this point has gained the attention of, particular, as one might suspect, given it's a Medicare benefit, that their intention to perhaps, can we save any money on nursing home, on short-term nursing home care as the first kind of phase there. But there are initiatives across the board, engagement with physicians, particularly specialists, consumer engagement, I mentioned, and if the group is interested, we can certainly share those 6 work groups. They're not public yet. They're not getting them. Right now, there's kind of a subset of staff are trying to plan and charge an engagement strategy, but we'll make sure everyone gets at least a notice on groups that are not.
Chris, I think in this context, there are 2 separate things. When we're talking about value-based contracting, we're talking about commercial payers or MA plans who are arranging to give a per member per month fee for somebody with serious illness. So I have a group of patients with serious illness, and I'm going to pay a contractor like MedStar or Gilchrist or Aspire, $600 a month each month for them to provide palliative care services. That's typically what we mean when we talk about value-based arrangements for community-based palliative care. I don't think it works in the hospital.
And I just wanted to add to that, as you know, the previous study was very much based on hospital palliative care. And the focus includes hospital, but more community-based providers and what's going on outside of hospitals. Were there other comments on the financing question 8? All right, the last section includes outcome measures, challenges, that should be interesting. And question 11, as I mentioned before, telling them which licensed agencies, facilities we're surveying, and just saying, other than those, are there some out there that we should add to our list to include? Dr. Grant.
So I think that you've got some of the key metrics here, but I think it focuses very much on the presumption of cost savings, which I'm not sure is always the case. So I just think that we need to include things like utilization or hospitalization and things like that. Because it isn't always cost savings. And I don't know,
Under 9A,
under 9A, yes.
and what would you add? Like
I think-
reducing readmissions?
So, you know, hospitalizations, readmissions, emergency department visits, those kinds of things. I don't know if it's worth asking if any of the programs are also monitoring caregiver distress or burden. We haven't talked much about caregivers. I know we talked about adding them as one of the service lines earlier in the survey.
Right, yeah, that may be beyond what we.
Yeah.
And just wanted to clarify on 11, we included the providers. So we had hospital, nursing home, home health, and hospice as included as settings. Hospice is a licensed provider that we will be serving. That's why it's included.
Can we add community-based palliative care programs in case there are any that are not hospice affiliated?
The other community-based palliative care.
Yeah.
Any other comments?
Against my point again, to shorten this thing, one of the comments I received was about asking non-palliative providers to identify the need or the gaps for us as well. So the oncology community, or, you know, I'm not sure how we would reach these people. You're boiling the whole ocean, but they are a group that would identify, you know, whether there's adequate palliative care services and, you know, are they accessible to their patients? But that would be a large group of whoever's caring for seriously ill people. I'm not sure how you put your arms around that.
I think beyond the survey, because the membership is representative of many parts of palliative care, that hopefully through their contacts, we will know, you know, more information that we could, this is the survey of like what exists, where are the gaps, and then beyond that, the report could be broader.
Yeah, and to the question, I think you make, it's a good one about how long it might take. I think as part of our plan, we would do some timings on, you know, response. I think you raise a good point. I mean, some of this information is going to be, they're going to have to do some pre-work and answer the phone, pick up the phone and answer some of these questions. Obviously, you have to be told that you're going to be called, and they would assemble that. Isn't that our anticipation?
Well, my understanding from discussing it with other states is they do set, they try to identify the appropriate person. They do send it out so that they're not just getting a cold call, and then they schedule the telephone call. And then some of them have detailed statistics on how many patients, how many visits. Others say, we're just starting, we don't really know. So it's not standard everywhere, and it's not easy to collect. That was my understanding. But I know it's been used. I could try to find out how long surveys take.
Other questions on this survey? We're up to 9, and then we have some open-ended questions.
Yeah, the only, the other part that I wanted to add, which we've already talked about, is if anyone had any questions. I know some of the other states have looked at just hospitals and hospices. We're trying to broaden that by looking at adding nursing homes, home health agencies, obviously, as we've discussed, other community providers identified in the survey. But is this the correct list, which is going to be quite a few providers? I don't see any comments on that. Okay, Scott Brown.
Yeah, good morning, everyone. I was just going to mention, going back to the metrics on the survey. Dr. Grant may have mentioned this, or she may not have, but another metric that you might consider is not just the completion of advanced directives, but of the Maryland Most form, and making all of those forms available once they are completed. That might dovetail very nicely with work that the MHCC is doing on advanced care planning document registries. And I know, for example, MedStar does a really good job of completing, translating advanced directives and advanced care planning conversations into portable medical orders and getting those to CRISP. So that might just be something else that you want to consider. Thank you.
Okay. Yeah, we do include questions on Holst. Mainly which forms do they fill out? I'm not sure. It's the
Yeah, I
jurisdiction
think
here.
that's a good point, and trying to kind of do another goal is always tricky, but yeah, we'll definitely think about how we could fold in some of at least awareness of some of the other MHCC initiatives regarding advanced care planning. Is a good suggestion.
Cindy Carter.
We are aware of the more questions we ask, the less enthusiasm we get.
Cindy, you had a question?
Yes, good morning. Cindy Carter with AARP. Are we not going to be, I notice all the people that we are sending this to. Are we not going to be working with community providers such as oncology, dialysis, a lot of the centers that are dealing with very seriously ill people?
What our charge is under the legislation is we're looking at licensed facilities and including those. If other providers are mentioned during the survey, because we already have quite a long list, then those will be added. And there were some mentioned today, like Aspire. So if there are other types of providers,
and I would add for that I don't think this survey instrument is the right one to use, because for community-based providers that treat seriously ill populations, there's just too much information that is of an institutional nature. But I think a shorter survey targeted might be useful. Right.
Peggy, I just wanted to check with you to see if you had any comments.
Thanks, Linda, and I do apologize for joining late. I had a meeting that I just couldn't get out of this morning that ran over, so my apologies for that. Yeah, I think the survey looks good. I think we're off to a good start here. Certainly, I know I'm meeting with my palliative care committee this afternoon, and I'm going to run this past them as well. So I think the more feedback we can get, the better. So I will certainly forward any comments that we have to you. But yeah, otherwise, I think it looks pretty good.
Before you came, I think there was some concern about the length of the survey. If you could be sure to ask your members to walk through this and contemplate.
And also differentiating hospice from palliative care.
Correct.
Yeah, I will be happy to do that.
Okay, thank you. Yeah, and the goal is to try to, get this wrapped up today or very soon, so that go ahead with the bid board and get the data.
Yeah, and to AARP's point, I think we'll look at how we might engage physician practices and others, dialysis programs, and gathering some information on their perspective. I think that's an important point.
Just one more comment, though. I did want to make, and again, I'm sorry if maybe you covered this, I joined late, but perhaps I don't see a whole lot on here about the caregiver's point of view. And I think that this survey is probably, like you said, Ben, probably not the right instrument to use to do this. But I think getting the caregiver's point of view is really important. I think if we really want to improve palliative care services, you know, that maybe we should take some time within this group to listen to some of the challenges and the barriers to palliative care that they are facing.
Yeah, I think that's what Cindy was mentioning earlier, and as Ben mentioned, the survey is really tailored to licensed providers. And I guess we can look at what mechanism would work in terms of addressing caregivers and caregiver needs. And Peggy, you may have some contacts or suggestions on best way to do that.
Okay. Thanks, Linda.
Thank you. Okay, oh, and then the other point on here, which we also discussed earlier, was survey by site or provider types, which is what I was talking about, where a nursing home reports that it has palliative care, it's providing palliative care when in fact it's has a contract with Hillcrest or another hospice to provide that care. So I think there are ways of noting in the survey that palliative care is provided at these nursing homes or these sites, but the provider is Gilchrist, so you're not double counting provider, or the provider is another hospice, but you get the site separate from provider because they may not be the same. In some cases, as Kathy mentioned, Gilchrist is the site of care and the provider of care, and others it may be different.
Linda, maybe what we did to question 5, when we would do the question. Yes, I have a formal program, but I contract with somebody else. Do it.
Well, what we're trying to do with 2 is, yes, I have a formal program. I contract with someone else, and then that's it. I'm done. I'm not filling out.
But do you want to know who they're contracted with, so you don't
Yes.
double count?
Yes.
See it in there, but maybe I'm not.
Yeah.
Properly.
Yes, under 3C, if so, with whom? That you do have a contract and with whom? Is that covered?
I guess I was reading, if I said above a formal, I could say yes. So I see, and then you go to 3, so you would have it there. Never mind.
Okay. Yeah, so there, if it's, for example, a nursing homes, they will say, yes, we have a program contract with Guilford. And that's it, or whoever else they, and then it wouldn't get into all of the else because they're not technically the provider. Which hopefully would reduce the questions. Okay.
Other questions from the listening audience? We've had a little conversation among ourselves here, but other questions from those that are online? Hearing none, Linda?
See any?
Okay, I think.
Okay, so in terms of next steps, as I mentioned.
Could I ask just one, I know I'm going backwards a little bit, the telehealth question that was mentioned, there is a mention of telehealth. You mind going back to that just for a second?
Yeah, well, Dr. Grant had added under 6E, do you use telehealth as part of that availability?
Yeah, so I mean, the reality is that very few programs would be available in person 24/7, 365. Most of them have on-call services where people can be, you know, calling at night or on weekends and even doing telehealth if necessary.
We also added under question 7I, does your program use telehealth, yes or no? And remote patient monitoring, yes or no?
That's right. Important, I think. I mean, of course, COVID made it very important, made it very interesting to do it. There was emergency coverage. You could bill for these services and all that. I'm not sure the status of that has been extended or is going to go away. But it is part of the future, I think, of community palliative care is telehealth. So I didn't know if it could be, should be, we dive into it any more than just saying, does it exist with any program?
Which would make it longer.
Yes.
Well, Chris, I think what is most important, I mean, the evidence suggests that palliative care programs are most successful when they have some kind of 24/7 coverage.
Yeah.
Because it's when people call at night or on the weekend when they can't reach their other providers and they have a problem, and that's how you possibly could keep them out of the ER. I mean, it's what the hospice has done forever. So I think it's more a coverage question than it is a telehealth question.
Yeah.
And you're right. I mean, so for instance, the billing for advanced care planning by phone only, audio only, will go away when the public health emergency ends, probably going to be sometime in January. So
I will take a little bit of issue with that it's only a coverage question, although I don't want to delay the whole meeting here endlessly. But there is a lot of work that is done routinely. Patients too sick actually to come to be seen in a primary care setting, who are cared for at home via telehealth. So there's a world there that, you know, that is being looked at and being utilized to some extent. I don't know how much.
So I think that's what our intention was when we talk about services. You know, do you use that or not? Yes or no? And then obviously we can follow up if we want more information.
All right. Thank you.
Yeah, and Commission will be releasing its report on continuation of the public health emergency telehealth waivers in the commercial market in 3 days.
Okay. Well,
but you know, clearly telehealth has become a major feature of the healthcare system over the last 3 years, and despite an initial reluctance to continue those, the momentum is definitely moving on to broadening what's going to continue after the public health emergency. Okay.
So as I mentioned, next steps, we're trying to finalize the survey and then do a bid board where we hope to have rapid turnaround to be able to start this data collection as soon as possible, because it will take a while to get the data. The next meeting is scheduled for January 9th. We can provide a progress report on the bid board and hopefully have a contract. We'll obviously not have any data yet at that point, but we can start on the other parts of the legislation, which deal with improving and expanding palliative care, and also discussion on financing and not what exists now, but what is needed in the future to broaden that.
And our plan, correct me if I'm wrong, is once we identify the contractor, there would be some polishing of the survey. We would, before it goes live, we would share it with members of this work group.
Well, I think we pretty much covered this.
Well, I'm thinking that perhaps the vendor, whoever that might be, might have some suggestions and tweaks. I mean, obviously, if it's the same, if there are no changes, which I find probably very unlikely, but major changes, we'll make sure that people here are aware of them before they go out.
Right. Well, if it's done before the January meeting, we can circulate.
All right. Any final comments from anyone?
Okay, thank you very much for your participation, and if you have anything additional, feel free to email between now and the next meeting. Okay.
Thank you very much, and we appreciate your attention to this matter and look forward to continuing this work over the year.
Thank you.